This is Selma Schimmel at ASCO 2011 in Chicago, and we're talking to physicians here about the latest research and clinical advances across many different cancer types. And now we're joined by one of the group room favorites, Dr. David Quinn, Medical Director, USC Norris Cancer Hospital, leader of the Developmental Therapeutics Program, and head of Genitourinary Oncology, all at USC, where you're also an associate professor, amongst other things, at the Keck School of Medicine. Thank you. And today, you're going to talk about all kinds of things as it relates to the prostate. Let's start with the Swedish study.
The Swedish study, excellent. This is a different Swedish study that looked at long-term screening in Malmö, one particular principality in Sweden, and we've had some updates over the years. This year, Hans Ledger, who's one of the principals who works at Memorial St. Kettering, will present some data that's very, very important. And it cuts to the issue of when we should start screening men with prostate cancer. Now, the problem with prostate cancer is it's very prevalent, but it doesn't kill many men. And from that perspective, it'd be nice if we could pick out men who were going to die from their prostate cancer or do badly and concentrate our therapies and our efforts on them, because we could then alter the outcome of the disease. That's been difficult to do. We've never been able to demonstrate that PSA screening combined with digital rectal examination has a benefit in terms of altering mortality from cancer to a significant degree for us all to agree that it's a good thing to do. This is despite the fact that we have some hints from various studies that there is a benefit, although it might be small, and that we have to screen a very large number of men to save one life. This study may alter our approach entirely. It looks at men from, in fact, before they're 40, and it goes back and examines specimens of blood for PSA levels. And it defines now, at least in that population, what a normal PSA is. And we used to think normal PSA was less than 4.0. It's very clear that in younger men it's much lower. But in the youngest group of men who are aged in their 40s, at a time when we wouldn't normally be screening for prostate cancer, most of the mortality occurs in patients that have a PSA greater than 1.5. And the various gradations of cutoff from there down also predict outcome. And so for the first time, there's a premise for us to screen men and potentially detect those who may be going to have some issues related to their prostate cancer, and also to select, on the other side of the coin, select a group of men who do not need to be intensively screened for their prostate cancer. And this is actually important. The men where we can say, look, you don't have to worry for 5 or 10 years, we'll re-examine when the paradigm shifts at your 50th birthday. That's actually kind of important. This actually has a really big implication in several groups of patients that have an excess risk of prostate cancer. In the United States, African American and Afro-Caribbean men have an earlier onset of prostate cancer and a higher relative mortality for incidence. And just why that is controversial. But certainly we do tend to screen African American patients as well as those with family history earlier. And there may be a premise now for going forward and investigating patients that in that younger group who have other things that might predict for them having a higher risk of prostate cancer that's going to be aggressive for us going on and investigating them and potentially treating them with things that can improve their outcome and decrease their chance of dying from the disease.
Dr. Quinn, please just clarify one thing. This speaks to men that are pretty young, 44
yes.
to 50. Is this geared for men that have never been diagnosed with prostate cancer?
Yes. So these are men who are healthy men living in our communities who would not usually have been screened until they were at least 50 years old. And I think this study is important for potentially starting to change the goalposts to focus our screening efforts on younger men, where if we intervene early, we may make a significant difference to the disease.
But that's it's sort of the whole controversy that we've had going from screening or not to screen, and there just seems to be there's no uniformity amongst clinicians to screen or not to screen.
Sure.
So this is a bit confusing in the sense that this study is raising the question, if you screen earlier, can you then predict the likelihood or risk of a patient developing metastatic prostate cancer later?
Sure. And so if you go back and look at those specimens and taken from the Malmo population, if the PSA for patients in their 40s was more than 1.5, they had a very significant chance of dying from prostate cancer when they were followed up for up to 25 years. So it's an early look and a potential for us to intervene in those patients.
Your personal recommendation for the average man is at what age to be screened?
So for the average man who doesn't have a family history, who's not African American, not Afro-Caribbean, my recommendation is that age 50, they have a full physical examination, including a PSA and a digital rectal examination, but also looking at their cholesterol, looking at their blood sugar, and also having a colonoscopy.
Yes, that's a real challenge to get men to do. Men and women at age 50 need to have a colonoscopy.
I think that what I tell people is that if at age 50 you've got a colon cancer, it's very likely to be early stage. You don't want it to impact you as you're retiring and entering your golden years. And if you have prostate cancer that's detectable at 50, and this is my pre-extrapolation before this data from Malmo, it's also very likely to be important. And if it doesn't kill you, it's actually likely to produce metastases in your lifetime, and therefore is likely to be worth treating. And I think we need to remember that we treat a lot of men who are in their mid to late 70s for prostate cancer. And the evidence for the majority of them, particularly those that have a low Gleason score, relatively low PSA, is that we don't actually impact the outcome of the disease very much. And I think we're wasting our resources in many of those patients. The problem is picking those patients where we're not going to intervene and transferring those resources selectively to a younger group of patients. The Malmo data suggests that we should be altering the paradigm and being far more selective, doing a sparser sampling. So it may be that we should actually take a PSA on everybody at age 40 as a routine, and we will then be able to segregate out the men who are going to have serious real prostate cancer that's going to kill them or produce metastases, and we can offer them early treatment. They may not wish to take that, but I think that it's an opportunity to alter a disease that's a scourge of men, certainly by the time they get to 60 or so.
And back to the man who is not at increased risk, starting at age 50 for their PSA, how often should that PSA be repeated?
Generically, we don't know. What I tell patients is that if they're having a routine health check, it's not unreasonable to have it as part of that check. If their PSA and their digital rectal exam are normal 3 times, then there is evidence that, as for normal mammograms or for pap smears, for example, that you can sample more sparsely, and you can probably go out to being assessed with PSA and digital rectal exam every 3 or even every 5 years if there's no indication of activity. Now, of course, the issue is that we have a very imperfect health system. The medical records are not contiguous. Communication is a big problem. So for men who go routinely to the one practitioner who looks after their health, they will usually remember to get it done. But working out whether this is their on year for PSA and a digital rectal exam is not something that necessarily most patients can handle unless they're really organised. Now, my view is that we should be helping them with medical records, but even the best medical records tend to extinguish certain data after a year or two, which when you're looking at the management of a disease state like prostate cancer, which has overall a slow evolution, is actually crazy.
Thank you. Dr. David Quinn, Medical Director, USC Norris Cancer Hospital, leader of the Developmental Therapeutics Program, and head of genitourinary oncology.
Thank you so much.
And best friend of the group room.